Well, hello and good afternoon, everybody. Welcome. There's over 100 of you with us today, which is rather marvellous. I'm not sure that we would have perhaps got quite a large congregation face to face. Perhaps we would have, but of course, COVID being COVID, our efforts to meet face to face were slightly confounded again. So apologies for that, but I hope we've done you justice. My name is Matthew Hayes. I'm the medical director of the Wessex Cancer Alliance, and welcome to our annual conference. We hope to hold your attention and harness your creativity until about 2:30 this afternoon. As many of you will already be aware, of course, Wessex Cancer Alliance is responsible for leading collaborative work to deliver high quality cancer services across Dorset, Hampshire and the Isle of and of course, that's only achievable by working closely with all of our stakeholders across Wessex. So I'm very grateful to you all for being a member of our gang, at least for today, and hopefully for rather longer than that. If I can have the next slide, please, Sally. We do our work through our comprehensive work programme, which of course covers all aspects of cancer care. You'll see our pillars of work here, from prevention and early diagnosis through faster diagnosis and the ambition to deliver on the constitutional standards, inclusive, of course, of treatment and personalised care, and underpinned at every turn by having a workforce that can deliver all of it. I really hope that you've enjoyed as much as I have browsing through what is, I think, the really impressive breadth and depth of our work and the detail of some of your projects during your virtual tour of the poster exhibition. They will, of course, all be made available to you afterwards. They are in virtual form on the website. They are in physical form in case we can ever get together and display them on a Velcro board with a cup of coffee alongside it. There really is something for everyone, I think, covering all aspects of cancer care, from children's cancer and genomic medicine through to improving cancer screening for people with learning disabilities, and inclusive, of course, of the provision of holistic multidisciplinary support for those living with a cancer diagnosis. And of course, there'll be much more to hear on that later. But first, I am delighted, and I mean delighted, to welcome on your behalf Joanna Calder. Jo has very kindly agreed to share with us all her very personal experience of the huge ongoing impact her cancer diagnosis had both on her and on her wider family. Her message is both powerful and important, and I think is probably the best possible starting point for the conversations which will follow. So I propose to shut up and introduce you to Jo Calder. Thank you, Jo. Over to you.
Thank you, Matt, and thank you everyone for listening to me today and having me here to share my story. My story of cancer began in 2014 when I was diagnosed with acute myeloid leukemia. And it was ongoing, sadly, in that I was in isolation for 8 months, continuously, albeit for a couple of weeks home, for a bit of a reprieve in between chemotherapy. I unfortunately relapsed within 6 months and got my acute myeloid leukemia back. I wasn't nearly as robust as I hoped I actually was. And I then spent a further 9 months in isolation in hospital, fighting for my life. And this resulted in a non-related stem cell transplant from an anonymous donor. I emerged from my treatment. I was still very ill and I needed to attend hospital between 2 and 3 times a week, and then monthly for the first couple of years for various different aspects of continued treatment. I reckon this gives me a unique insight into the needs of a cancer patient. I have visited just about every department in hospital apart from the morgue now, really. And I felt I was kept alive for a reason. The stats on me surviving were extremely low. But I've set about championing the needs of others by campaigning, lobbying, and being appointed to a variety of different roles in both the voluntary NHS, research and charitable sector. And I hope that they have allowed me to make a difference, but it's been incredibly tough at times. I've been exposed to standards of excellence in other patients and their carers' experience, but also gaps in need that need a voice for improvement. This improvement, I feel, has to be in personalised care and the support and care of the patient's carers. The patient's carers are neglected, in my opinion. There's no point spending millions keeping me alive if the life that I live is not a supported whole. The NHS saved my life. It physically saved my life. It was incredible, and the debt I owe is unsurmountable, but it's only half of me. The other half is my physical and social needs, and the impact my diagnosis and treatment has had is immense. My daughter was 13 and my son was 15 at point of diagnosis, and my husband had to give up full-time work. When I had my stem cell transplant, by the time I came out the other end, my son was 17 and my daughter 15. But when I was discharged, I was still acutely ill, and the roles were reversed in our household, and my daughter became my carer. My son was away at school. This has resulted in her needing to go in and out of eating disorders units. She's attempted her life twice. And it's this bit of my diagnosis that makes me angry, because I believe that with the right care and support, this could have been prevented. I had to prepare my children for my potential death. I was given 2 months to live, and at the time they didn't have a match for me. There was no stem cell donor apparent. I like to think it was my sister campaigning outside her local station that got to find my ultimate donor. But even with him on board, I was only given just over 30% chance of survival. I also, ironically, am a nurse. I'm a general nurse, but I'm also a paediatric nurse. And I ironically nursed some of the initial children to have a bone marrow transplant in London. They all died, horrendous deaths. And so my needs at that time prior to transplant were acute because I didn't believe I was going to survive. I still remember writing those memory letters to my children and making recordings of singing childhood lullabies, which is what they'd asked me to leave them as memories. There was no help for me with this. I couldn't find any help on the internet at the time either. Nobody asked me if I had needs at that time. There are finite resources in the NHS, but there are some amazing charities out there that need to be signposted to more readily and repeatedly. The Cancer Map, it's a terrific resource and regionally linked. It has some incredible small charities which are uniquely funded. And these charities I have subsequently found and been able to use, but I wasn't made aware of them at any point during my care. I wasn't asked enough, if at all, if I'm brutally honest, whether I needed some psychological input. I should have been. I don't want to, appear ungrateful that I'm alive, because I'm really not. And I feel reticent to complain. But I have suffered from a form of PTSD. And it wasn't until several years after that I started to experience it in the form of panic attacks brought on by visiting the unit that I had once been in. I think as a whole, I think you've never really fixed a patient till you fix the whole of them. And if I had a few points that I would like to ultimately ensure that my voice enabled at the end of this chat, it would be, please use charities more. Lots of patients are afraid to generically look things up on the internet. They need to be signposted more readily. There needs to be posted on every wall, in every region. There shouldn't be a blank bit. Slap them up, especially in isolation rooms. Ask patients about their psychological well-being repeatedly and often. And if you don't have the time, which I know you don't as a clinician, particularly in our patients department, to address that question, say to the patient, I don't have the time to, or the expertise, but I know somebody that does, and here they are. And well, that's probably it. And I hope my words have had some sort of meaning and purpose, and I hope they've resonated with some people, and I hope that in a small way they might make a little difference. Thank you.
Thank you, Jo. I probably set you up to fail in describing you as the best possible starting point for the conversations which were to follow, but I don't believe for a moment I did. Thank you for your honest challenge, and for your courage, and for the reality that you exemplify thousands and thousands of people for whom we share some responsibility. The trite thing is to say, well, follow that. But of course, we have to follow that. We have to listen to Jo's story and to those of the many people that she represents, and rise to that challenge. And of course, that's what we aim to do, as exemplified by what we've touched on already. We have some time, and I haven't asked Jo whether she's willing to take questions, but of course, if she is, we will take questions for Jo. Perhaps if anybody's got any immediate ones, please feel free to do so now. Otherwise, we can of course come back to them in due course. Patricia.
Thanks, Matt. I'll put my camera on. Hello, Jo. My name's Patricia Miller. I'm the Chief Executive of the Dorset Health System. And it's not a question really, it's more of a comment. So I had breast cancer right at the beginning of the pandemic. And I had fantastic clinical treatment. But actually, what it made me think about afterwards was that we spend a bit too much time. This is not a criticism of healthcare, because I've been in healthcare for 34 years. I love it. But we quite often see the person as the disease that they present with rather than the whole human being. And what I discovered from that was, well, yes, I had fantastic treatment for my breast cancer. Nobody thought about the fact that I was in the middle of the menopause. What would that mean? It was an estrogen-driven tumour. I couldn't take any of my medication anymore. Nobody has still thought about what that means for my bone health. There were a whole lot of questions and follow-ons that were an impact of having cancer that not one single professional thought about how I would be able to access the right support or get the right ongoing treatment that would manage those things, because they were so focused on just curing that one thing. And I think that probably happens to lots of people. And so we need to think about what the whole person needs, what the ramifications on their life of that disease will be, and how we then support them with that ongoing journey. I was really lucky. I did get offered psychological support, but because my breast cancer nurse regularly asked me to fill in a questionnaire about how I was feeling. And one of the questions was, do I feel I need psychological support? So I did get that, and that was really helpful. But I think we've got to stop seeing conditions in isolation rather than thinking about the impact on the whole person, their family. Because actually, when we don't do that, we might cure that thing, but actually it leads on to other things in that person's life that then have an impact on their overall health and well-being, their personal happiness, and their ability to live a long, healthy life.
Thank you, Patricia. Jo, you couldn't get a more senior person echo your sentiments. Anything you want to say in response?
I think it just mirrors my own experience.
Yeah.
Wholeheartedly. I think, similar to you, Patricia, I was shoved through the menopause at 45. It wasn't until I had the courage to mention something which is very personal, especially when you're younger than everybody else experiencing symptoms, that was addressed. And it wasn't addressed particularly well until eventually I went to see somebody privately. So yes, I totally endorse what you're saying, Patricia. I think we have to look at people as a total whole and not a collection of symptoms. Absolutely, totally.
So, Jo, I don't know whether you live in Dorset, but you might want to move to Dorset because your voice has been heard. Andrew Merwood.
Thanks, Matt, and Jo, thank you for your account. It was really touching, and I'm really grateful to you sharing that today. So I'm a psychologist based in Portsmouth, and a lot of what you said resonated with me. Not just about the need for us to be mindful and to repeatedly ask about the psychological needs of people, because we know that's going to change day in, day out, week in and week out. But I think the thing that struck me most was it was the wider systemic impact, if I can call it that, the impact not just on you, but on your family. And I know a lot of my oncology colleagues will think of systemic therapy as being kind of chemotherapy. Of course, as a psychologist, I think systemic means the wider system, the family that you're in. I think that is an area of unmet need, and maybe this is an unfair question for you, Jo, but I wondered from your perspective, what do you think could have been done better to support your family as you were going through treatment? Because clearly that's a big piece of the puzzle.
I've spoken to somebody who I've spoken to loads of different people with hematological cancers now in a variety of different arenas, but I spoke to one individual who'd been to the Marsden, and after her initial chemotherapy, after the first consolidation of 2 months of chemotherapy as an inpatient, she had a psychologist come to her and ask her what she envisaged her children's needs would be. And her retort to that was, I've only got an 18-month-old. And she said, she was told, yes, but that 18-month-old won't be 18 forever. And your treatment is going to be protracted over several years. And I think it was hearing that probably made me the most angry, because I thought, my God, so that's such an inequality in health across regions, because there was she being asked about her child who yet to establish needs, and I had children with real tangible needs that weren't asked about. So yes, maybe we should be looking at the patient as a whole from the outset, and because particularly, as a parent, if you know that your children are in need, your ability to focus on survival is compromised. So it does affect the outcomes of survival and overall success. And it shouldn't and couldn't potentially be a costly injection of cash to do so, hopefully.
Thank you, Jo. And we'll be hearing more about psychological support, of course, very shortly. Christine's got a question, but I'm sorry, Christine, to disappoint you. I think we probably do need to move on. Perhaps you wouldn't mind communicating with Jo either in the text or separately. Thank you again, Jo. If I may, we'll come to Jane Winter. Jane is our lead nurse and lead for AHP, Allied Healthcare Professionals, who's put together with our colleagues a couple of more detailed presentations around some of the aspects of the work that we feel would be of most relevance in terms of both Joanna's story and where we need to get to. So over to you, Jane.
Thank you, Matt, and thank you, Joe. I mean, it was incredible, of course, and I think there isn't a person in the room who isn't reflecting on that now, and probably may not hear the rest of the afternoon. We'll be reflecting on it for a long time, I'm sure. And I think the important thing for us as an alliance is that we really consider that we think, you know, we've got survival rates and treatment rate data which show that we're, you know, the best in the country, but actually the experience of care is never going to be less important. So we really need to make sure that we address the issues that you've raised, and also that we demonstrate through what we're going to talk about this afternoon some of the advances we have made. We're going to expand on some of the work that was in those posters, and really try and show the success that we have as an alliance. We, you know, obviously we've still got things that we need to change. We've still got people we still need to listen to, and we'll never be complacent in that. We'll never assume that we touch everybody and manage to address everybody's needs, but we'll constantly be looking to improve. And our success as an alliance is dependent on those relationships with people like yourself helping us and keeping us totally grounded. We're really reliant on our partner organisations, so our partner organisations in places like HEE and the Academic Health Science Network, our partners in Macmillan, in the voluntary sector in general, and the way that we work in an integrated way across primary care, community services, and secondary care, of course. But more importantly, I think that our work is not just grounded in experience, but also grounded in our clinical and the knowledge from our clinical colleagues. So the backbone of our work really is that it's clinically informed by our site-specific groups, by our clinical reference groups, and that we think of delivering care at a number of levels. So we think of it really being delivered at a system level. So we plan with our partners in at a system level in the integrated care systems. We think about how that looks in an organisational context. So how do we then support our organisations to deliver the cancer agenda alongside the number of other competing demands and agendas that they have? And then what does that look like at a personal level? Because that's ultimately what matters. We never lose sight of those people on the receiving end of care, as you say, and it's not just at that pivotal point in time, it's the legacy of that and the continued support that can that we need to make sure is accessible for everybody. There's something for us to consider about the integration piece as well. You know, cancer isn't in its own bubble. Most of our people that access our services have other morbidities. They have other conditions and other competing demands on their time, and actually either we need to support the existing healthcare teams that are supporting those individuals and their families by wrapping around some cancer knowledge and expertise, or we need to be able to minimise the number of people that individuals have to see on a daily basis. We have examples of people who, you know, with multiple morbidity that will have 10 healthcare professionals coming into their homes throughout the day, most of whom try and come in within about half an hour of each other. It's really difficult, you know, and we want people to continue with their lives, but support them to do that. The posters, I think, are a great example of the pieces of work and the innovation that we're able to support. A lot of those posters were an individual in a clinical team in an organisation that had a great idea but didn't know how to bring it to life, didn't know how to raise it to the attention of the people with the power, I guess, in their organisation. So what we can do is take those ideas, support them to develop them, and wrap that structure around them. You know, support them to do business cases, do the impact assessment. There isn't a piece of work that we do that we don't evaluate or do an impact assessment alongside, because it's so important that we're spending money in the right way and impacting in a way that really transforms people's experience of care. So I think the important thing for us important thing for me now is to hand over to Steph Heath, who's our lead for our personalisation of care programme, and she's going to talk about the personalised care agenda and the work that and give us some examples of the work that she's doing. Steph.
Thanks very much, Jane. I'm just going to share my screen very quickly. Happy to bear with me. I've just got a couple of slides for you. So I wanted to thank, before I get started, thank Jo for her honesty in terms of sharing her experience. I think we'd all agree this is something that it's so valuable for us to hear and to receive that reality check. And I think a lot of what Jo describes sits very clearly front and centre in our personalised care works programme. And what she describes is that when people receive a diagnosis of cancer, they need so much more than medicine. People need and they deserve a pathway of treatment, care and support that's humanised, and one that respects the complexity that we all have within our individual lives. That support that's both timely and flexible to those needs, and support that's compassionate. And within Wessex Cancer Alliance, we have a huge responsibility in terms of delivering that, but it's one that I feel we commit to wholeheartedly, and I hope that's evident in the sort of programme of work that we're focusing on at the moment, and within the evidence from the poster tour that you've seen. Over the last 2 years, the NHS has faced unprecedented challenges, but I think what we've witnessed within the personalised care work programme is that continued and growing commitment from all our stakeholders to be working differently, to be thinking differently, supporting people proactively and collaboratively, so that we better understand the different needs and different levels of complexity and thinking about how we respond to and meet these needs. We know that there's loads that does need to be done. There's lots of improvements to make. But I think it's also an opportunity today to think about what we have gained so far, and for us to take the opportunity to celebrate some of those achievements. And I hope that poster tour gives you a flavour of some of the things that we want to be shouting about and celebrating, and also where we're focusing currently. So within the personalised care programme, and what you'll see from the poster tour, and actually one of the key messages from Jo's experiences, we know that there are significant unmet needs relating to psychological support. And to do this well, we need a workforce that's resourced, that's equipped, and we need to invest in that. So our work within the psychological support mapping at the moment is not just thinking about numbers, but it's also thinking about skill mix, about understanding training so that staff feel confident in having these really challenging conversations, but also have the support and the supervision in structure in place so that we know that that support offer is sustainable. Our psychological support programme is also allowing us to take a really deep dive to help us understand what we've got, but also what we need. And as Jo so clearly pointed out, it's thinking beyond psycho-oncology services, thinking also about our third sector providers, the services that we have outside the cancer settings, and how we use those resources effectively. Our alliance within Wessex Cancer Alliance is thinking about ambitions that are wider and align with wider mental health services. We want there to be no wrong door for psychological support within cancer pathways. We want that support to be visible, readily accessible, and for pathways to be joined up. We're also thinking more creatively about using new roles and how we integrate better with services. And in 2023, with the support of Macmillan, we'll be piloting new posts with mental health practitioners working within cancer teams. We also know, and you'll see from our programme, that there are benefits of early intervention support following diagnosis with rehabilitation pathways. So pathways that offer that health and wellbeing support focused on emotional well-being, nutrition and access to exercise. The challenge is that we know that only a small percentage of people with cancer can access this currently. So one of the projects in our work stream at the moment is scoping to help us build and understand what we have and be better able to tailor our approach based on need. We're also learning about models of rehabilitation delivery via programmes such as a pre-op vet project, helping us to understand how these can be integrated within pathways. You'll also see from the poster tours some of those ideas and quality improvement initiatives that have grown from frontline practitioners about thinking about new ways of working to provide that support offer in different ways, particularly in the poster tour focusing on nutritional support and level 4 psychological support. Finally, within our work programme, we've got an amazing and dedicated cancer workforce, and as Alliance we want to invest in that expertise and grow our talents. Traditionally, cancer nurse specialists have been the cornerstone of personalised and supportive care, and for people with cancer and their families, they're often the person that's the first point of contact, and they're constant within pathways. So we're incredibly proud that the first module of the new cancer nurse specialist academic pathway was the Principles of Personalised Care module. And this demonstrates our Alliance commitment both to investing in CNS talent and academic development, but also investing in education focusing on personalised care. What's important, I think, also is the personalised care module content was shaped by a range of stakeholders. This includes people who are experts by experience. A big part of this development is also about positive role modelling. Our amazing pathway lead and a high proportion of our module presenters were experienced cancer nurse specialists. And so it's an opportunity in that module to celebrate what we do, to value that role and value how they bring personalised care to life. Our short-term ambitions that we apply for Personalised Care Institute accreditation of the CNS module, but we're also thinking forward to the future about translating that content to other roles within the cancer workforce, but also the option to translate the content of that to specialities outside of the cancer setting. We're also expanding our education offer in personalised care over the next few months as we roll out a new accredited health coaching programme open to all roles within the cancer workforce. We're also currently investing in primary care mentorship, education and resources to deliver high quality cancer care reviews and support and education for social prescribers, providing that team-based support to care. I think for me, one of the things within our work programme is thinking not just about what we do, but actually how we do this and what is our ethos around which we practice. I think from listening to Jo today, we can all recognise that the value of learning from lived experience and actually needing that whole person, whole family approach. We know that people come with solutions, and that creates an opportunity to work with individuals, to work with communities and use that energy to better shape the needs of future services around people and communities. We also need to have a workforce that's resourced and skilled, but also enabled to deliver personalised care. If our lens is only focused on what happens in secondary care, we've got a really restricted view. So we need to open this up and see cancer in the context of people's whole lives and where they're living that, and make that support more meaningful. So we need to think differently about where and how we deliver cancer specialist support, but also how we upskill the generalist workforce to deliver quality personalised care within cancer support offers. And I think there's an exception that we can't do this alone. We need to work together with different services and to show that we're connected with the people that we're supporting. One of the projects I wanted to take the opportunity to showcase that I think really brings our ethos and our way of working to life is the Right by You Wessex initiative. So something I hope you had the opportunity to see in the poster tour. This is a Cancer Alliance and Macmillan Cancer Support initiative that we are piloting in 2 sites across the Wessex region, in West Dorset, in Portland and in Southampton City. And it's about how we work differently and challenge our traditional approach to Southampton support, to cancer support, moving specialists outside of the hospital setting and putting them alongside people and communities, working with them closer to home and focusing on the things that matter to them. An evaluation of this project will be available in June 2023, but some of the key messages and questions that we're asking of the evaluation is what happens when we move those supported conversations outside hospital settings and traditional clinic rooms, when those conversations happen with people and the people that are important to them in places where they feel comfortable, when places that are familiar to them, somewhere that looks and feels like home, whatever that may be for the individual. When that support offer is open and conversations allow that person to have the agency to set their agenda and talk about the things that matter to them. And what is the value when that cancer specialist has the opportunity to give you that unhurried time and reflective space to talk about the impact of cancer for you and your loved ones, and has skilled and supportive conversations to help you address your emotional well-being and to enable you to have choice and control in your decision making and your plans of care. What we're also asking is, what are the benefits when that multidisciplinary team supporting you isn't tumour site specific, but perhaps formed of people that are involved in your wider health and care needs, perhaps involving specialists from other long-term conditions, from community teams, from your primary care team and services that are offering wider support. And what happens when we recognise that there's a different type of expertise required, and our role should be supportive of you and the expert that you trust and have that relationship with you, so together we can access support that is right for you. So on that note, I'm going to end and hand over to two of my colleagues that are actually bringing that ethos to life, working within the Right by You service. So firstly to the lovely Angela Ingram, who's our cancer nurse specialist that's leading on the implementation of Right by You in Portland, and then to Pam Campbell, who's a nurse consultant with experience over 30 years working within the homeless healthcare team that's supporting the service delivery in Southampton City. So over to Angela.
Thanks, Steph. I've had the absolute privilege of working as a Right by You CNS for almost a year now, having come from secondary care background. It really has opened my eyes in more ways than I thought possible, seeing people in a place that they feel more comfortable, which is normally at home, although it is very much patient-led, so sometimes I have taken people off for walks, and I have had one gentleman who wanted one of his visits in the pub garden. I did not have a drink, but it was where he felt comfortable talking to me, so that was fine. And it made me realise just how much we don't see about our patients and their families and their lives when we are seeing people in the clinical setting. It gives the opportunity for our conversations to be truly led by the patient and what matters to them, rather than having some agenda in secondary care. Because normally when people are coming for a clinic appointment, we have some form of agenda, be it discussing diagnosis, symptoms, treatments, whatever. But I've really found it's given the patients that I'm seeing the opportunity to talk about the things that are worrying them. And a lot of those things you raised, Joe, is psychological support and support for the wider family and carers. So it's also been linking in with the primary care team, and that has worked really well. We've been able to work together, but we're also linking people into those community and voluntary services that are out there, to try and provide the support that they may not have realised was available. We do this by doing a health needs assessment. I tend not to do a form, but we work through those same questions just in a conversational way, to make sure that I'm not missing anything. But normally people are very open to talking about everything that is concerning them. I'm also linking in with a local community group, the Lantern Trust, who provide support to vulnerable communities and homeless, those with mental health issues, and they refer people to me. So sometimes I actually see them, see people there, and that again has worked really well. And more recently, I've started seeing people with cancer in one of the local prisons, and the plan is to start seeing them in the other prison as well. That is an area where people don't get the opportunity to address their psychological concerns in the same way. And as you can see, there's already a big gap for most patients, but in prisons they don't have the same access to the CNSs at the hospital. There are particular barriers around phone calls, which is understandable, but it does mean, you know, that access to support by phone from the CNSs at the hospital isn't always there, because, you know, if they don't pick up the phone, you can't say, oh, well, phone me back later, in the same way that somebody in the community would be able to. Yeah, so I think that sort of sums up roughly what I'm doing. I could go on for a long time because I'm very passionate about this job, but I will stop there.
Thank you, Angela. And you're passionate about it because you can tangibly feel the difference you're making. And I think, you know, all staff really want to feel that when they walk out of their job at the end of the day, don't they? And I think we're so excited by the work that you're doing. So thank you so much. And Pam, can we hand over to you, Pam, too, for, I'm sure, an equally stunning and passionate...
Sure. For a very brief catch up. So my role within Right By You is to work with people experiencing homelessness or people on the move, people seeking asylum, migrating for a variety of reasons. And like Angela, learned so much. Despite 30 years in primary care, working with people experiencing homelessness, there is a broader sweep, and I think everything I've heard so far resonates with the work I do. And I suppose the strapline I would bring you to is partnerships beyond cancer services. You know, we desperately need the services that provide the treatment and the care, but what we're listening to is Joanne's experience of life and relationships and where you sit. And a very handy little acronym that I keep myself focused with is, you know, housing providers, outreach, making every contact relate to a person's experience. So just remembering home. So if you looked at my poster today, you'll have seen the place where my very first referral back in October a year ago lived in Southampton, which is not a million miles from where we're sitting now, but very, very different context. So the opportunity to work with people who are experiencing multiple exclusion homelessness challenges our concept of home, and unless we accept that challenge as not the individual's obstacle but the obstacle of the system, we're doing everything Joanne would encourage us not to do. So once we turn that on its head, the issues become not the individual's problem, the individual's diagnosis, everything that wraps around them, but how we tackle them with the system. So when the Red Cross say to me, you know, we don't lend wheelchairs to people living in hostels, that's not an acceptable stance to take. And so it's learning how we push those barriers back and create, you know, somebody at the very beginning at 12 midday talked about equality and diversity here. Unless we do that and advocate for that for all of our patients, then we're missing a huge trick. So personalisation for me allows me to adopt that stance that the problem doesn't lie with the individual, it lies with the way we've allowed systems to solidify around them and we don't push them. You know, somebody having to collect their supervised consumption of methadone and get to their chemo appointment at 9 o'clock, you know, no brainer. We can make this happen for an individual. We don't have to. You've got to get to the chemist, then you've got to turn around and walk 3 miles across the city to your appointment. And going out to what people call home, which will challenge all of our concepts of what home is. And the other thing I think which really was very powerful about what you said, Joanna, was relationships. I'm building memories, but usually with people whose relationships are frayed to an extremely thin level. They maybe haven't seen their parents, their siblings for 15, 20 years sometimes. So how do we leave those messages, even for their children that they've not been in contact with? And I think that's a real challenge to us in creating those opportunities for people. Because when you do experience homelessness or you're living in a hotel full of other people who have been on the move with you seeking asylum, your structures are shaky, to say the least. You know, what holds you in isn't necessarily around you anymore. And sometimes those people you are with, you need to create relationships, and we need to acknowledge those as bereaved too. Don't get me started on public health funerals if you want to continue the afternoon, but we need to change things that are out there that really disqualify our patients from a normal and humane service. I think that's all I want to say. Thank you.
Thank you, Pam. And as ever, you constantly keep us on our toes in terms of challenging our notions of who we aim our services at. And that's so important, that we really are, really open things up so that we don't cater for a certain group of individuals in a certain place at a certain time. And the work that you've done has been phenomenal. So thank you. Thank you so much. I think if it's okay with everybody, we'll move swiftly on to Kathy and Mary. And Mary, your work, your poster work clearly already has raised a lot of questions. So we're very excited, Mary, to have you here to talk about the work that you've been doing with us around the R's roles in cancer. So I'll hand over to Mary Edwards. Thank you.
Lovely, thank you, Jane. To follow on for some great conversations that we've had already, and I've got a few points that I've kind of written down from the comments that Joe made that we can hopefully discuss a little bit here. But what I'd like to discuss now is a project that I've been working on, looking at the additional reimbursement roles that sit within primary care and how we potentially use them for cancer care. So as you can see down the bottom right hand corner there, they're the roles that sit within under the additional reimbursement roles. And for those of you that are unaware of what they actually are, they're actually funded roles currently within primary care to look at kind of widening the multidisciplinary team. And obviously we're very interested in kind of personalised care and how they meet that agenda as well. So they can categorise really in those support roles, assistive roles and clinical roles. Some of these roles are quite well embedded already, so many might have heard of the social prescribing role. The paramedic role has rolled out quite well in primary care, and so is the first contact practitioner and MSK physio and the clinical pharmacist. So their role's quite well embedded, but other of them are kind of more new or potentially more innovative. And because there's a shortage of some of those professions, you're not going to see them readily available, but we do have some examples of them across the patch. So this project is to look at developing a toolkit that we can share with primary care to help them kind of think about how these roles can be utilised. But it's a toolkit for the actual post holder to use to link them into education tools, patient materials. So it's to make it as easy for them to kind of upskill and to support cancer patients within primary care. So as it's a Wessex Cancer Alliance Health Education England South East funded project, it's 18 months duration. We're working very closely with other programmes because it sits under kind of their programmes of care as well, personalised care, primary care, education and early diagnosis areas as well. And we are linking closely with cancer education programmes such as the Ascend, Prosper and Macmillan as well. So from a driver's perspective, obviously there's quite a few primary care drivers, the NHS DES contract, the QOF, thinking about the long-term plan and very much that universal personalised care model. And we're waiting on the cancer 10-year consultation, which will obviously be a driver around this. From the perspective of the actual patient, we learn a lot obviously from the national surveys that happen, National Cancer Experience Survey, the Cancer Quality of Life, and also locally we've done our own kind of Right by You Wessex Voice Patient Engagement Survey, where we learnt a lot about what patients' needs are and what their wants are. From the post holder perspective, we really want the driver around that is really to kind of engage these roles within cancer care, looking at growing a cancer workforce. We want to offer opportunities and progression within these roles, but really to raise their profile and what they can do for cancer patients, and as an alliance, how we support that development. From an integrated care perspective, it's easy to kind of see where these roles sit within that, thinking about PCNs as that neighbourhood now, and how the initiatives around how we develop our services to work in partnership with other sectors. And if you look at the social prescriber, that's a really good role to kind of show that one of their roles and responsibilities is to work at place. So they should be working with their community to look at what the patient population needs are, and actually driving change within services as well. Thinking about tackling health inequalities, the great thing about working within a PCN is to be able to look at your patient population and their needs and to drive forward care around that. So if we think about kind of prevention and screening within primary care networks and what these additional reimbursement roles can be employed for, they can actually tackle health inequalities really well. And there is some evidence of them doing that already from a cancer perspective. So we've just gone live with the toolkit, which is on the Wessex Cancer Alliance website. So we're starting the promotion of that, and I'm happy for anybody to contact me to discuss, but we'll be doing a really good drive on that, going ahead with that. We have started to look at proof of concept sites, so to work quite closely with a few PCNs, just so that we can have a chance to try out the toolkit and really work towards upskilling some staff and collecting some data and evaluating that, how it's working for them, so that we can obviously improve the toolkit as well. I've been working very closely with Tamsin, who's one of the primary care network practice managers, who's working to promote the cancer care coordinator role. We've been doing kind of working towards driving employment to do webinars so that we can show how well they can be utilised for cancer care. And we've started a community of practice. And going forward, we hope to kind of bring a few more primary care networks in to kind of test the toolkit, and then we'll be looking to kind of evaluate how that was all gone and carry on with our dissemination and promotion of the toolkit. So the toolkit is there for the additional reimbursement roles. So it's very much there so that they have their own space to go to and find the necessary things that they need, and they're not having to kind of traverse lots of different things. They can hopefully just pinpoint what they want, with lots of kind of support documents to do that, be it their supervision, and linking them into groups that hopefully can support as well, be it peer or supervisory. It's also a resource for employees to understand the potential of the roles, how they meet the responsibility of primary care and the universal personalised care model. And it also provides things like recruitment support documents so that they can, you know, just progress really quickly with those things. But it also enables us to, as an alliance, to basically support them, learn from them, you know, promote opportunities, promote best practice, and just learn about those workforce needs. So that's the link to the toolkit. I'm sure we'll be sharing these presentations, so that'll be on there, and we can probably put it in the chat feed now. But when you go on there, you'll see that there's a button for each role, so that you can click on that. And when you go into that, there's 5 drop-down boxes. So hopefully it just enables people to go to exactly what they want to do from that. I'm not going to go too much into it, but there's lots of kind of support documents in there. So what is the big deal about cancer care coordinators? So we're really trying to promote this role at the moment. There's many reasons why it could be really helpful. We're already getting some anecdotal evidence about how helpful these roles have been. And I'm sure there's some people that can comment on that are on this conference anyway. But thinking about how it's easy to show how they help achieve the GP contract DES and the QOF requirements. But we're finding that it's very supportive to patients and carers at many points in the pathway, and it can really kind of support that use of digital tools and data collection to help with population health or tackling health inequalities. And it's a role that potentially we've got more opportunity to recruit from, and we're finding that they're coming from a very varied background. So from the proof of concept point of view, we're hoping that from having these smaller kind of proof of concept sites, we can really delve into, you know, how these can be utilised for cancer patients, how useful the toolkit's been to them, what the impact has been on other members of the primary care team by kind of upscaling or looking at innovative ways that we use these roles. We obviously want to hear about the patient and public experience, and we're hoping that we can show some cancer care innovation in primary care also. So I just wanted to reflect a little bit on some of the kind of data that is collected through some of these surveys, to think about how these R's roles may potentially impact. So if you look at some of these questions that were asked through the National Cancer Patient Experience Survey, you'll see that, you know, this is consistently not much change, I think, from the last one that was done. Most patients don't feel they get enough support at home from community and voluntary services, and that's before and after treatment, before, during and after treatment. And historically, this seems to be the problem, that they still feel that they don't get the right support from their GP practice during treatment as well. And then this might be, I don't know how true percentage this is, but saying that a patient had a review of cancer care by GP practice, only 15% at the moment. Now, that may be because that's not their understanding of perhaps having a cancer care review in primary care, potentially, but they're still not understanding that potentially that those questions are being asked and there's support available in primary care. So from an R's perspective, it's easy to see how the support roles could be really, really useful to kind of drive up how we use community and voluntary services, helping to signpost and working collaboratively with those if we use those roles correctly. I also wanted to point out in the Cancer Quality of Life survey, the areas that seem to be most problematic for people with cancer are around work and leisure and are around social. So you can really see how these kind of social prescribing roles might be really, really effective if we use them correctly to kind of support cancer patients, potentially after treatment as well might be more significant how we support them. And then from the point of view of the regional questions, when we've asked, you know, how would you like to develop your local cancer services? If you look at those things that are underlined there, a lot of them are non-clinical support roles that can help with that. So thinking about signposting, transport and finances, wanting support the whole way through, and thinking about kind of those different support options in their local communities. And just to pinpoint really on some of the things that Joe said that really resonated with me and some of the feedback we've had, you know, it's about as much about how we support the people around people that are being treated for cancer. And, you know, when we look at social prescribing, that's been really useful in doing that. But also about, you know, having someone there who's a link that you can contact, and having that continuity of care is also coming across as really important. So that's it from me.
Thank you, Mary. We could, of course, listen to you for a long time, and also really appreciate the transferability of the work that you're doing into the system. It's not just about cancer. All of the work you're doing is going to be adaptable for PCNs moving forward. So thank you. I'm going to hand swiftly over to Kathy because I'm mindful of time. And thank you again, Mary. That's great.
Thank you, Jane. Thank you, Mary. I mean, I agree. It's an absolutely fabulous piece of work, and that's just one aspect of the cancer workforce programme that we've got there. And I echo everybody's thanks to Joe and also Patricia for your open and honest account of your experiences at the start of the day. And Steph, through her presentation, has clearly articulated, I think, the need for that skilled and enabled workforce and the integrated roles, the education that's needed, the support that's needed, and the growing of the workforce. So I will try and summarise very quickly the workforce programme, given the times that we've got. Don't strain your eye looking at this slide. I make no apologies though, because that's perhaps what I clearly want to show is actually the enormity of the cancer workforce. It's very complex. It touches many specialities and goes beyond the many expert cancer specific roles. So if we look at the orange, we've got the obvious workforce groups within that, the cancer clinical nurse specialist, the therapy radiographer, the clinical and medical oncologist, the haematologist, the oncologist psychologist, many more there, the SAC nurses, the acute oncology nurses, but also in terms of a cancer workforce, I think we need to think about the generalist teams as well, who are supporting the diagnostic process and some of the treatment sides, including the pathology teams, the imaging teams, all the primary care teams that Mary's talked about, surgical teams, those in the care home, and also the hospital infrastructure of admin and porters. So when we look at the workforce like this, you'll see the enormity of the workforce programme, as all of the workforce is under pressure. Naturally rising demand for cancer services from an ageing and growing population, as we've said, often with complex multimorbidities, exacerbated by the pandemic, has impacted such that demand outstrips capacity, both within the diagnostic pathway and in the treatment space. And I've yet to speak to a workforce group that are not under extreme pressure. So the workforce pillar, as clearly articulated by Steph, and Mary, it's a key enabler for all of the other programmes of work too. Without the right staff in the right place at the right time, we will not achieve our ambitions at all. So just thinking about our workforce strategy here, and the link to the workforce strategy is in the top of the slide, and I'm sure that we will share this. It's on the resource table on the Wessex Cancer Alliance website, but I'm going to use some of Matt's words in the forward of the cancer strategy, and that sort of those of us working in the cancer arena, whether patient facing or not, continue to strive to make real and sustained improvements in outcome and experience for everyone living with cancer. And without question, there is a real challenge at the moment in doing this when the NHS remains under significant pressure. One of the greatest assets the NHS enjoys are the people working within it, and so nurturing and developing such a workforce must be one of our highest priorities if we're to succeed in delivering our aims. And without the right people doing the right things, we won't succeed. And those words are still relevant now, sort of 8 months on. Thank you, Matt. So we have to make sure that our cancer workforce strategy has to ensure that we support and re-energise the workforce following the challenges brought about by the pandemic, as well as to enable and drive the change we need to be fit for the longer term. We need to build on the positive changes that were necessitated by the pandemic and embrace the opportunities for changing service models, introducing new roles, and adapting new ways of working. And we can only do that by working with all of our alliance partners, ensuring the alliance leads where it needs to, it supports where it's required, and we share always so that none of the workforce initiatives are in isolation. So we, as an alliance, can provide the cancer services lens into the integrated workforce transformation plans of the ICSs. And it's been reassuring through our workforce programme board meetings and other workforce steering groups to share the ideas and progress that we're making, such as Mary's project, with our ICS workforce leads, and also to hear their plans to ensure that cancer is embedded in the wider NHS workforce strategy. We've got close collaboration with the Academic Health Science Network, fantastic opportunity, got a dual post there, so that we're able to be cited on any technological innovations that would support the workforce, because expansion of the workforce is not through just training more people. We have to think about it in terms of expansion of capacity of the workforce. And this can be done through a skills mix approach, utilising technology to speed up, automate, standardise and standard processes so that the workforce can work to the top of their skill set. We partner with third sector charities. We work superbly locally with Macmillan support teams. We work with service development teams. And we share their excellent education resources, which are now available to sort of all healthcare professionals. We work really closely with our HEE colleagues across both the South East and the South West, the Cancer and Diagnostics team, the Advanced Practice team, the Workforce Transformation teams. We try to ensure that all their education grants and training and support offers, endoscopy imaging, training academies, workforce transformation funding offers, they're shared, supported and utilised. And we work with our NHS regional leads. We work with the Wessex Imaging Network. We work with the Radiotherapy ODN in terms of the workforce. So this slide is just a snapshot of the partners we work alongside, and I'll apologise now for any that are missing from it. So the central aim in terms of workforce strategy, as with all the work at the Alliance, as Steph has eloquently said, we have to go back to the person with cancer. And what we want is that workforce equipped and enabled to provide the high quality care for cancer patients. And we need the workforce in the right numbers, with the right role design, with their attractive career pathways, and they need to feel valued. I'm just going to forward quickly to the next slide. To highlight really the mood of the workforce. Around 60 cancer clinical nurse staff specialists were asked to reflect on the last 2 years, i.e. over the pandemic, and provide 3 separate words to describe how they felt. The words in the large font were repeated many times: challenging, exhausting, emotional, tiring, frustrating. There are a few positive words in there, such as rewarding, liberating, team building. But what I think this slide shows is that we've got a workforce out there who are surviving rather than thriving. So there is an immediate need to support, to energise, to value the workforce so that we avoid further attrition and reduction in capacity. And key aspects of our programme of work really over the past few months, led by Jane, has focused on this provision of CNS and AHP development days, compassion fatigue training, supporting the development of the career framework, which Steph mentioned about, with the modules developed by Helen Perry around psychological assessment and support and personalised care. And indeed, the CNSs attending these courses have already highlighted the value of the courses, saying the opportunity to take the courses has been so relevant to their work that it's actually made them think twice about something they were thinking to do, which was leaving the profession. If I go back quickly to the strategy, the second part is about having the right skills, values and behaviours. And we've talked, Mary, eloquently again about the generalist and the specialist roles and making it fit for the future. We're committed to making sure that all the workforce groups have access to appropriate education and development opportunities so that all are aware at the most basic level of cancer and its treatments, have the ability to listen and respond appropriately when supporting people and their families with cancer, and know where to confidently signpost people with cancer and their families and friends for support. So Mary's outlined some of this work in terms of the primary care toolkit. Alongside this, we've got an education resource page that shares links to credible, usually free and very relevant development opportunities for all across all the care sectors and beyond. And we run regular webinars, which are really well attended. And of course, there's something that can be viewed in your own time. And finally, the third thing is right place, right time, cancer treated as a long-term condition. And again, the integrated patient care across primary, secondary and social care. And in view of time, I won't dwell on that because Steph and Angela and Pamela have really eloquently talked about that. But what we will do is just show the programme overview for the workforce. And you will see from that, again, it's a busy slide, it's a busy programme of work. We work with many clinical advisors on this, and you will have seen some of the detail of the projects in the poster presentation. But the key aspects really of all the work that we're doing in terms of the workforce programme is around that workforce transformation. It's looking at challenging the ways that we currently work, supporting teams to work at the top of their skill set, upskilling professionals where we can, providing that career progression, introducing new roles like the pathway navigators, the physician associate roles, composite roles, integrated roles, looking at a skill mix approach within the team and introducing new technology where that is appropriate. I'm very happy to answer any questions about any of these aspects and any of the workforce posters. But at that point, I'll probably hand back over to Jane in the interest of time. Thank you very much.
Thank you, Cathy. And I think generally it would be really helpful if anybody has any questions to put them in the chat. And what we'll do, because I'm conscious that we're all going to run out of time, and I don't want to cut Nicola's piece short, but equally there are going to be so many questions. What we'd like you to do is put them in the chat, and then we'll build a Q&A document which we can put on our website. And of course, any other questions, you've all got our generic email account. I can feel Heather already twitching at the thought that people are going to send questions into Heather. But, please, any questions. We don't want to shut down the dialogue. We want to open up the conversation. So we'd really welcome your questions. And I think just to bring everything back a little bit to the people again on the receiving end of care, I think it's really important we hand over to Nicola to talk about the work that she's doing in her work programme.
So I'm just going to talk about one of the projects that we have in the prevention and earlier diagnosis pillar of work, which is trying to help us achieve the earlier diagnosis ambition of 75% of people being diagnosed in stages 1 and 2. And this is the Communities Against Cancer programme. So this, I wanted to talk about this project because I think listening to Joanna's account and experience has sort of reminded us about the personalisation of care throughout treatment. But I think it also makes me think about how we almost need to personalise some of the messages that we need to send out about prevention and earlier diagnosis to the communities within Wessex. And this project is based on a peer education model, which has obviously seen, has evidence to show that is more successful in getting messages across to particular communities. This project is about reaching communities and raising awareness of cancer to help improve their health outcomes. So as you can see here, the main aims are to increase the awareness of signs and symptoms of cancer, to encourage people to seek help at an earlier stage, and to encourage people to take up screening, also to help people to live more healthily, because obviously there are the preventive measures that can help people as well. So let me just talk a little bit about the model. We're actually in phase 2 now, but in phase 1 we commissioned Action Hampshire, who are a voluntary services organisation, to work across Wessex and investigate local groups, to link with them and to discuss with them projects and objectives. So they are out there having those discussions with those communities. And they offer them training for any of those community members, but especially if people are looking to have a grant to do any work. The messaging in the training is around prevention, it's around cancer screening, it's around signs and symptoms of cancer, and it just gives a better understanding of what cancer is and what's out there to help people. And also they spend a great deal of time working with those communities if they want to apply for a grant to help them shape what they can do, but not to overly encourage particular models, but just to help them be within our criteria. To essentially spread that word into their community, the best way that they can do that. So who are we working with? We're focusing on communities, the seldom heard communities, so minority ethnic communities, people with learning disabilities, people with serious mental illness, communities who are struggling financially, and anyone with protected characteristics. So a really broad group of people, but those people that we think may be less well informed, and to help them to be more informed. Let me just talk about some of the grant applications that we have had. And of course, as I said, not everybody applies for a grant. So this is a small number of people, a small representation of people who have been engaged with by Action Hampshire. So, but they have been, the ones that have applied for grants have been a wide variety as well. So as you can see here, we've got Home Start Wessex, which works with younger people, younger families rather, which was obviously an interesting and slightly different group for us to talk with. Autism Unlimited also have applied for a grant and been successful. Winchester Go LD, which is a group who work with people with learning disabilities, and also Citizens Advice have applied for a grant too. So how do they work in their communities? And the answer is such a variety of different ways. I just thought I'd give you a few examples of how they've done that. to start with, we have 5 different radio stations who are engaged, which is absolutely phenomenal. And we even have our own jingle on one of them, which is great. And they communicate to different audiences across Wessex. Let me just give you an example of one, which is Awaz Radio, who are mainly in Southampton, targeted at the South Asian population, although it is wider, and it does even message out to Birmingham now, we've just heard. So that's fantastic, slightly outside Wessex, but interesting to see their reach. So they have all of their articles on their website as podcasts, and they've been doing a suite of interviews and articles around cancer. And when they had a look at their statistics on their website, they had noticed that the podcast about prostate cancer is the most downloaded that they have. So I think that's just really, really interesting, that people want to understand the messages that we are trying to get over. So other groups that have chosen to deliver things like cook and eat sessions, so working with low income groups, people with learning disabilities and BME groups as well. And the organisers do this, so they do the cook and eat, but they're talking about how that relates to preventing cancer, and also talk about understanding signs and symptoms as well. One of the citizens advice officers have been training their advisors and their support staff, so about 50 people in all, and they've been training them on key cancer messages. They've also been working with some of the cancer charities to stock appropriate leaflets and posters as well, which has been really positive. So it's quite a rounded piece of work there. There has been a cancer information video that's currently being developed by autistic people for autistic people. So that's a really positive way of getting the messaging out in the appropriate way for that audience. We have also funded a walkthrough app about breast screening, which has been developed for people with learning disabilities, so that they can understand exactly what's going to happen when they attend their appointment, and who they'll speak to, and where they will go. So really good for reducing anxiety. And just, you know, the final example here, we Age UK applied for a grant to enable them to speak to their groups while participating in health walks, but also demonstrating healthy eating as well. So I think that's really important, because obviously this is the population that's most likely to develop cancer, and so understanding when they should be contacting the GP is really important, and understanding that symptoms sometimes aren't just about them getting older. So let me just touch on a little bit about the successes. So this is phase 2 of the project, which started in January 21. It will finish this year in December. Since the beginning of this phase, workshops have been delivered to 160 people by Action Hampshire, all the way across Wessex, and that's both community members, mostly community members, I will say, but latterly some NHS staff. So some of those people that Mary's been talking about, some social prescribers, health and wellbeing coaches, and cancer care coordinators have been attending the training as well, which has been seen as really positive by the community, having spoken to some people about that, because they see that if the training is being delivered to NHS staff, that it must be high quality training. So has worked really, really well for people. So 42 grants have been awarded over that time. I will say not all applicants are successful, but most are, with some tweaks, and the team at Action Hampshire are brilliant at going back and working with those groups to see if they can tweak things to be more appropriate and to fit in with the criteria that we hold. And so far we've awarded £164,000 to community groups to do our work out there, to message for us, and to do it in appropriate ways for their communities. So the message is getting out through them, which is fantastic. The project is going through a robust evaluation at the moment, and that's being carried out by the Centre for Psychological Research in Cancer that's at the University of Southampton. That will give its final report in March next year, but some interim reports are going to be giving us an idea about whether we will actually have a phase 3, which we would like to have, phase 3 of Communities Against Cancer. So that's all I wanted to say about that. If you'd like to find out more, I will put in the chat the website for Action Hampshire that you can go and have a look at. So thank you very much. I'll stop sharing my screen.
Thank you, Nicola. The energy and the enthusiasm that you all put into your programmes of work is phenomenal. And the way that you work for the greater benefit of people on the receiving end of care, and the synergy that you get from those relationships that you build with the communities that you work with is just phenomenal. And that coupled, I think, with all of the programme leads have such a natural curiosity about your programme of work, and a real drive to deliver your programmes of work. I just say it makes you really proud. Makes me really proud to sit here and watch you present your work, because I know how much work goes on in the background. So I just want to say a massive thank you to you all and everybody that did the programmes, and of course Gemma, who has pulled that wonderful presentation together. And Gemma is the beavering away in the background to bring all of our work to life, and not least the Twitter feed, which is constantly going at the moment. Gemma, I can see it coming through, the stuff that's being tweeted at the moment. So your multitasking talent's quite incredible. And thank you so much. As I say, we will put a page on the website to make sure that we answer all of your questions. We've got a little bit of time now, not least to say we all want to hear the jingle, Nicola. There seemed to be a lot of love in the room for the jingle.
I don't have it here.
Oh, okay. Okay. And I'm conscious we will run out of time, and I just wanted to go back, of course, and thank you, Jo, for just introducing your life and yourself to us, but also that I hope that everything that you feel that you've said today, that runs through the work that we do. And if not, tell us, hold us to account, because that's, we're here to spend money wisely and make sure that we deliver services that are responsive to need. And if we're not doing it, we need to be told. So please do. It's a very exciting partnership. So thank you. I'm conscious we have got some questions. So we've got 5 minutes. I don't know whether to prioritise and take it in order. I know, Christine, we cut you off earlier. Did you want to pick up on your question?
No, I can catch up with Jo afterwards. I suspect Matt and Sally will kill me for announcing this publicly, but I just think that Jo's talk was so powerful that we as an organisation would do very well to use it again to try and engage with the ICB, was what I was thinking. I suspect Jo has seen some of it, but I also wanted to reassure Jo that I would hope that some of the issues that she experienced when she was first diagnosed may have improved in terms of our cancer care coordinator in our network, picking up some of those issues with her family. But no, it was mostly to say it was amazing. And anyone who's brave enough to talk about morgues in a cancer talk would certainly get the attention of the ICB, I think. So thank you.
Not least for your nursing humour, I think, as well. I think that comes through, doesn't it, as well? And also actually to say thank you to Patricia for sharing your experience, because that was totally unprompted, and thank you, because it's so important that everybody feels comfortable to talk about their experiences and make everything that we do better for people on the receiving end of care. David, hello.
Yeah, thanks, Jane. So for anyone who doesn't know me, I'm David French. I'm exec chair of the Wessex Cancer Alliance. I'm also chief exec of UHS, and Jo, we spoke, didn't we, a couple of days ago. That was terrific. Thank you. I think the challenge for us going forward is how we practicalise, if that's a word, some of Jo's suggestions. So there's clearly something about signposting. And as Joe was speaking, I was reflecting on, you know, how do I, as a chief exec of a hospital, evaluate the performance of our teams? And often we will look at 5-year mortality. In other words, the way that the specialties and the teams are monitored and evaluated is all about treatment of the disease rather than treatment of the person. I'm interested to hear whether any of the docs, we've got a few on the line, how we start changing that, but it's a sort of top to bottom change that we need, starting from, you know, people like me. How do we evaluate the performance of specialties across a hospital down to individuals? If we haven't got time now, then that's fine, but I think that's the topic that the Alliance needs to pick up and move forward. Thanks.
Thank you, David, and of course, yeah, vital, of course. And Steph, I'm sure you've got lots of thoughts around that. So yeah, we need a sort of part 2, a follow-up now, don't we, to make sure we put our money where our mouth is. Patricia.
Thanks for this afternoon. It's been really, really interesting, and there's just a few points going through my mind. One, when we talk about experts by experience, do we actually, a question that we can answer later on, that do we actually use an experience-based design approach? I've worked in my last organisation where I was a chief exec, where that was really well embedded in the organisation, and that meant that we were using that toolkit to test the emotional and psychological responses of patients as they were going through pathways, which is really powerful, because we think we organise things to be more efficient for them. So we talked earlier on about 10 people can go for a house in any one day. Well, I remember setting up a head and neck cancer service that I thought was a brilliant idea, that the ENT surgeon and the max fact surgeon saw the patient at the same time. And when we put them through the experience-based design process, they said, actually, it's scary enough talking to one consultant when you have 2 in a room. We're never going to ask a question. So we do things that we think are good for them without necessarily understanding whether they're good for them. There's also something in my mind about the work that's being done around bringing care closer to individuals with the pilot site at our end in Portland is really, really important, because again, as a provider chief executive, I lost count of the number of times I had conversations with patients that were along the lines of, I've been started on another round of chemotherapy. I know it's not going to work. This person is trying to save my life and I just can't bring myself to tell them to stop because I want a palliative option. So when you introduce a different environment with a different professional who's less threatening, you're going to get a different type of conversation around people's options. So I think that's really, really important. My last point was more, well, 2 points. One was more about what we do around the next development and model, because we've talked a lot about the fact we need to do more work on redesigning services, and the NHS sometimes cannot want to start something until the plan that it's got is perfect, when in reality people learn more as they're doing, so you can start without the plan that crosses every T and dots every I. So I'll just leave that there. And then the final point in my mind was about the non-statutory support that Joe talked about. So as part of developing our integrated care strategy, I've been quite clear with our system that it has to be community driven, to the point where the community need to write the vision, not us, because we're here to serve them in terms of their needs. And one of the things that has come out of the engagement exercise, where we've done lots and lots of interviews with members of our community in their own homes to try and understand their own lived experience and why they're not achieving good health and well-being. One of the key points that's come back is, please can you make sure that non-statutory services are bolstered, because when things go wrong for us physically, emotionally, mentally, that's where we go first. So I think that understanding of what we need to do to invest in the third sector, because we do it really poorly in health, the value that we get from the third sector, which is way more than we get at the NHS or the private sector, and being able to signpost people to those services when they're going to, before they're going to need them, is really, really important, because that's where the wraparound support comes that we quite often can't give.
Oh, thank you. I think you've just rounded up the whole conversation really, really eloquently. And just in terms of actually not ending it there, but what next? The so what bit or the so that bit, that we bring in services and work with our partners so that, we do deliver the care that's needed moving forward. And thank you. And thanks to everybody. I'm conscious of time, and I'm conscious that we really we did say that we close bang on time. So I apologise to anybody, but please do put your questions in the chat if that's okay for everybody. Is there anything else that you'd like to round off with, Matt, if we close this down?
I don't think there is really. I mean, I echo everything that has been said. The signposting message is clear. It's great to hear that you can access Right By You even in the pub. Not that that's necessarily the right place, but it is a place. Eamon, I don't know whether you have something brief to say, but we're out of time. So please do interject if you wish.
Yeah, I think just a quick one about equality as a cross-cutting theme in everything we do, because even with psychological aid, and I made a couple of points in the chat section, is that when we are now looking, we are really now into diverse communities, because in those places psychological care and support should be really tailored to the unique cultural differences between these communities, and some of them it can be intertwined with spiritual care. And just to come back to David about the point about how do we measure as clinicians, I think we are very much driven by numbers rather than by quality, David. And I would say, it's always easier to show I've done 100 cancer operations than I have 20 patients who think the world of the cancer services at UHS. How do we measure that? Again, we measure the negative when we have a problem and we end up having to do a root cause analysis. So I think it's a question of whether we invest in getting qualitative data from our patients who when things go well or not go well, and then feed that back to the Wessex Alliance and other people to say examples of good practice and examples where things can work better. And the mechanisms are there. And I think it's just directing those mechanisms into sources of information, which the Alliance and other partners who can learn from best practice locally. We don't need to look elsewhere outside the patch of our hospitals and providers to get good examples of things which work well, and integrating ourselves secondary and primary care in small pockets, and then see how that works overall. Sorry, Matt, I just wanted to babble those things through.
No, it's great. It's a really important message, and I hope that from what everybody's heard this afternoon, you can see that we take the addressing of inequalities and inequities very seriously indeed. It's properly written through the work programme, but we must continue to address those. Thank you all so much. We're slightly over time, and I'm a little bit late for joining another meeting, so we must move onwards and forwards. Thank you again to Joe. Thank you to everybody else for joining us. I think 125 is pretty close to a record for us. So thank you all. We will be back to you in due course to create a new agenda for the future based on both what has been achieved and what we still need to achieve. Thanks again. Enjoy the rest of your afternoons.